So there will be 2 lectures in my series. This is the first one, and this will be on peripheral nerve disorders or peripheral neuropathies. Right. So these are the objectives. I am supposed to show the objectives at the beginning. These are the objectives for the first lecture. So it includes the definition, classification, causes, pathophysiology, diagnosis, etc., etc. And there will be 2 examples, and then the prognosis. The next lecture will be on polyneuropathies, and it will also have a segment on nerve injury. So there will be a segment on peripheral nerve injuries, because I thought that won't be covered in other lectures. Okay, so we will get on to today's lecture. Right. So when you take peripheral nerve disorders or peripheral neuropathies, they can be broadly categorized into 2. One is focal neuropathy, the other one is polyneuropathy. Focal neuropathies are mononeuropathies and mononeuritis multiplex, which will be dealt with in the second lecture. And today's lecture will be on polyneuropathies. And you will notice when you read books, the term peripheral neuropathy is used to mean polyneuropathy. So it's a bit confusing, but the correct term is actually polyneuropathy. Because when you say peripheral neuropathy, it will include all the diseases which affect peripheral nerves, and that includes focal neuropathies. So polyneuropathies. Polyneuropathies are generally disorders which affect peripheral nerves, and they are usually symmetrical and usually widespread. The most important feature is there is simultaneous involvement. So the peripheral neuropathy affects peripheral nerves on both sides of the body, left and right, and they affect simultaneously. And sometimes it can start in one region and spread to the other region. For example, it can start in the legs and spread to arms. But usually they are roughly symmetrical. Okay, so this is just to show you the peripheral nerve. And when you take a motor nerve, they start in the anterior horn cell, and then you have the root, plexus, and peripheral nerve ending up in the neuromuscular junction. So we are concerned about this area. So actually the nerve root is the beginning of the peripheral nerve. And in the upper limb and the lower limb, there is a plexus which it goes through. So normally the root and the plexus disorders are dealt separately, but it's an artificial division because this is the proximal end of the nerve. So some peripheral neuropathies actually do affect the root as well. So then we call it radicular neuropathy. Of course, anterior horn cell is not included in the peripheral nerve, but in some classifications, when they talk about peripheral nerve disorders, they even include the anterior horn cell. And then if the disease primarily affects the anterior horn cell, actually the correct nomenclature will be anterior horn cell disorders, but some people call it neuronopathies. But that is the older term. The term neuronopathies is not used nowadays. We call it anterior horn cell disorder. So, but we are dealing with the peripheral nerve disorders. And also in the case of sensory nerves, you have sensory dorsal root ganglion. So if it is a disease affecting the dorsal root ganglion, strictly speaking, it's not a peripheral nerve disorder. It's called a ganglionopathy. And same is the case for autonomic nerves. If it is a peripheral autonomic nerve that is affected, it's a peripheral neuropathy, autonomic neuropathy. But if it is affecting the ganglia, then it is an autonomic ganglionopathy. So now I think you should be clear what we are going to deal with. We are going to deal with the diseases in the peripheral nerve, not the anterior cell, not the dorsal root ganglion or the autonomic ganglion. Okay, so you must remember that there are sensory nerves, there are motor nerves, as well as autonomic nerves. And you must not forget the cranial nerves. So when we are dealing with the peripheral neuropathies, it also includes, in addition to spinal nerves, the cranial nerves are also involved. Right, so this I have already mentioned about the dorsal root ganglion and the anterior cells. So now the pathology. So if you take the peripheral nerve, it consists of an axon and a myelin sheath, and there are some nerves which are unmyelinated. So here we are going to deal mainly with myelinated nerve fibers, so myelinated nerve diseases. So the disease process can primarily affect the axon. So the primary damage could be in the axon. Then we call it axonal degeneration or axonopathy. On the other hand, the disease process primarily can affect the myelin sheath. Then you call it a myelopathy. So these are the basic two pathologies which affect the peripheral nerves. So whatever the insult which causes the peripheral neuropathy can either primarily damage the axon or primarily damage the myelin sheath. Then there is a third pathology which has come through, which produces what we call a conduction block neuropathy. And there the pathology actually affects the node of Ranvier. That's the other structure that is there in the peripheral nerve. So we call it nodopathy plus paranodopathy. But in your case, I don't think it's necessary for you to remember this or mention this, say at your exams, for example. So if you remember the first two, that should be enough. And the third one is for actually postgraduate level. Okay, so this is just to illustrate graphically what happens. I think I will get rid of this. Okay, right. So this is a normal axon which represents the peripheral nerve. You have the axon and the myelin sheath, and this is how the nerve impulses travel. They jump from a node of Ranvier to the next one, which is a fast process. And you call this, what do you call this? Anyone? This mode of nerve impulse transmission is called? Someone. That's right. Very good. Yeah, that is called saltator conduction. So it jumps from one node of Ranvier to the other, and it doesn't go through the myelin sheath. Myelin sheath is actually an insulator. It doesn't conduct any electrical potentials. So it can jump from one node to the other. The nodes are separated at about 1 to 3 millimeter gaps. Okay, so that's how it happens normally. Now, when there's demyelination, the myelin sheath gets damaged. So the myelin sheath is not there now. So then what happens to the nerve impulses when they come jumping from one node to the other? When it comes here, what will happen? I think I'll get the mouse connected. Give me a second. Right, so what will happen when the myelin sheath is not there? The nerve impulses which reach the point where there is demyelination, they either get lost because they cannot jump because there is no nearby node of Ranvier. So therefore the impulses either stop there, which is called a block, or the impulses can travel like in an unmyelinated nerve. In an unmyelinated nerve, the impulses travel by depolarization of the nearby membrane and gradual propagation of the voltage change along the membrane, like this. So this is a slow process. So unmyelinated nerves carry impulses very slowly. It can't jump from a node to node because there are no nodes. So two things happen there. Either the impulse can get blocked or it gets slowed. If it gets slowed, it doesn't really matter much because finally it can reach the other end of the nerve and impulse can travel. But if it gets blocked, then the function of nerve stops. Okay, so that's how demyelinating neuropathy produces its symptoms and signs. Now, this is an example of conduction block neuropathy, which I told you don't have to remember. Here it happens at the node of Frenvia where the impulse gets blocked due to the problem that is happening at the node of Frenvia. So I don't go into detail of that one. Now the bottom picture shows what happens in axonal degeneration. So in axonal degeneration, the axon dies. And these axons die in response to whatever the impulse, the insult that damages the nerve. And you know, in peripheral nerves, we have what we call exoplasmic transport. So exoplasmic transport happens centrifugally, start from the nerve cell and travels towards the periphery. And it carries whatever the ingredients that are necessary for maintaining the integrity of the nerve fiber, because the whole cell contains the axon as well. The supply of exoplasmic transport is best at the proximal end, and it is worst at the periphery. So supply is very poor at the periphery. And if the axon is long, the situation becomes even worse. So the supply is from Colombo and supply to Jaffna is poor. It is very far away. Supply to Hambantota is very poor. It is far away. But supply to say Battaramulla, Pragama, Homagama, which is here, it's better. Right? Okay. So when there's some insult which tends to damage the nerve, it happens at the periphery because it doesn't stand the insult. So therefore, the longer nerves at their very end gets affected first. So the longest nerve in the body are in the legs. So therefore, and in the leg, the distal most end, the foot area, the peripheral nerves are most vulnerable to axonal degeneration type neuropathy. So now you may realize this will explain some of the symptoms that we come across. That is the symptoms and signs that we come across. Right. So polyneuropathies we can classify them into mainly two categories based on the pathology: demyelinating neuropathies, axonal neuropathies. Then you can further subdivide them into acute and chronic, which is a simple concept that you come across in any illness. By the way, can you hear my voice clearly?
Yes, sir.
Okay, good, right. So then there will be four categories ultimately. In two axes. So in this axis you have acute and chronic, and on the other axis you have demyelinating and axonal. So now you have four categories. And if you draw this table and try to fill these boxes with the possible causes for these neuropathies. So you have acute demyelinating, acute axonal, chronic demyelinating, chronic axonal. And now look at the acute neuropathies. The commonest cause for acute demyelinating neuropathies, acute inflammatory demyelinating polyneuropathy. If you have learned Guillain-Barré syndrome, this is Guillain-Barré syndrome demyelinating type. Then there are other acute neuropathies, for example, diphtheritic neuropathy, nowadays virtually non-existent because we have eradicated diphtheria. And there are only very few other causes here. Next, we will take acute axonal neuropathies. You can have acute motor axonal neuropathy, acute motor sensory axonal neuropathy. Both are two forms of axonal Guillain-Barré syndrome. So they are axonal Guillain-Barré syndrome. Then the next cause is porphyria. Neuropathy due to acute intermittent porphyria neuropathy, which is also very rare. Now you can see that if you take acute neuropathies, whether it is demyelinating or axonal, the commonest cause is Guillain-Barré syndrome. So if you have anyone presenting with acute neuropathy, remember you have to prove that it is neuropathy. If it is acute neuropathy, it will be Guillain-Barré syndrome until proven otherwise. You can have acute symptoms due to other causes. But if you are able to prove that it is neuropathy, then it will be Guillain-Barré syndrome until proven otherwise because of the commonality. The other causes are extremely rare. Now we will go to chronic neuropathies. Now take chronic demyelinating neuropathies. You have only a few causes. CIDP, chronic inflammatory demyelinating polyneuropathy, hereditary demyelinating polyneuropathies, so Charcot-Marie-Tooth disease, for example, demyelinating varieties. Then you have paraproteinemia. Then you have drugs, and out of drugs also you have to remember only one drug, amiodarone. So these are the causes of chronic demyelinating neuropathies. Now you go to chronic axonal neuropathy. Here you have a whole heap of neuropathies. If you read a list of peripheral neuropathies, a list of causes of peripheral neuropathies or polyneuropathies, this is the list you come across. And these are actually causes of chronic axonal neuropathies. You have metabolic, you have diabetes, which comes under metabolic, and you have toxic, you have hereditary axonal variety neuropathy. Then you have drugs. And here you have a whole heap of drugs. Right. Now I will give you a tip to remember these causes and their pathologies. You remember these three boxes. And here you have to remember Guillain-Barré syndrome. You are 80% you are okay. And if you remember these few causes, whatever remaining will fall here. Okay? So you can do the other way, but it's easier to do it this way. Remember these three boxes, then anything else will be right. Will be chronic axonal. Now, how do you diagnose a polyneuropathy? So that is the most important thing when it comes to managing a patient. So you go by symptoms and signs. So you'll have motor symptoms and signs, sensory symptoms and signs, autonomic symptoms and signs. So motor symptoms and signs will be those of lower motor involvement. So the lower motor involvement will be weakness, wasting. Fasciculation is a lower motor sign, but it's extremely rare in polyneuropathies. And patients can get cramps. So these are painful contractions of muscles, which particularly happen at night, and especially in the calves. Then you have diminished or absent tendon reflexes. Then you can have deformities. You can have deformities in feet, foot drop, or you can have clawing of toes, and you might even recognize wasting of foot muscles in the case of foot. Then in the case of hand, you might recognize clawing. You may recognize wasting of intrinsic muscles. You can see dorsal guttering between the fingers. I will show you pictures of clawing in the next lecture. And then you can also have a wrist draw. And if you actually properly examine, you will be able to demonstrate the weakness. Then in the sensory examination, sensory history, they will complain of numbness. And numbness is a non-specific term. What do you mean by numbness? Actually, it means sensory disturbance. And it can be either reduced sensation or hypoesthesia, or it can be increased sensation, hyperesthesia, or it can be altered sensation, dysesthesia, or paresthesia, I'm sorry. So it may be pain, hyperalgesia. So various symptoms can happen, and our patients will come and tell you numbness. And you have to ask them, is it reduced sensation, or is it altered sensation, or is it spontaneous sensation, pins and needles, or is it pain, or so on. Just to characterize, say what they mean by numbness, because some people come and tell you numbness, but what they really mean is weakness. So that you have to clarify here, and then you check the distribution from the history as well as from the examination. And some people might complain pain, They might tell you that they have severe burning pain, shooting pain, or sometimes stabbing type pain. They say it's like a knife, being put through their limbs, stabbing type pain. And some people have ataxia. They are unsteady on their feet, they are ataxic, and this is due to sensory ataxia. So you have to differentiate this one then from cerebral ataxia by examination. Then if there is autonomic involvement, they might have cutaneous autonomic symptoms like lack of sweating, then change of blood flow, causing change in skin color. Then they can have loss of hair. Then they can have GI symptoms. If it's affected, then they may have cardiac symptoms, postural hypotension, heart rate changes, tachycardias, bradycardias, and so on. But autonomic neuropathies are relatively uncommon. So once you identify the symptoms and signs, you must identify the pattern of distribution, and this is what guides your diagnosis. And there are common patterns. In the case of chronic neuropathies, it can be distal symmetric pattern, usually starting the feet and then spreading to hands, or it can be distal and proximal symmetric pattern. Usually polyneuropathies are symmetric, we mentioned at the beginning. But this is in the case of chronic polyneuropathies. If it is acute polyneuropathy, the story is different. It can be actually any pattern. It can be distal, it can be proximal, distal and proximal, symmetric, asymmetric. Sometimes it can be distal in the legs, proximal in the arms, or the other way, proximal in the legs, distal in the arm, and so on. So there's no particular pattern for acute neuropathies. So diagnosis of acute neuropathy is a bit difficult clinically. So chronic polyneuropathies. So, and we divided chronic polyneuropathies into two, axonal and demyelinating. So first axonal neuropathies, and we just referred to this picture earlier, and we mentioned that the longest nerves are affected first. So the longest nerves are in the legs, and therefore the legs are affected first. So therefore in the legs also the distal most part, so the toes will start getting the sensory symptoms, and the weakness, so power involvement, motor involvement will start again in the feet. But in the feet, the muscles are the intrinsic muscles, and the patient may not feel the intrinsic muscle involvement in the feet, because unlike in the hands, the intrinsic muscles in the feet don't do a big job. So therefore, the motor symptoms in the feet can be a bit late. Now then what happens? The degeneration spreads proximally. So it's called dying back phenomenon. The degeneration spreads proximally. And then the shorter nerves start getting affected. So it will start in the toes, gradually spread proximally. Then the shorter nerves, very less longer nerves can get affected. And that produces the sensory symptoms spreading proximally and the motor symptom signs spreading proximally. So when it spreads proximally, then the muscles in the foreleg below knee will become weak. So tibialis anterior can become weak, that produces foot drop. And then the calf muscles can become weak, then they will have difficulty standing on their toes. And by the time the symptoms spread up to, say, mid-calf or knee region, the length of the nerve in this segment will become equal to the length of the nerve in the arm. And then you start getting symptoms in the hands. So you will start getting sensory symptoms in the fingertips, gradually spreading proximally. Then the motor symptoms can start in the hands. So you will have weakness of the intrinsic muscles in the hands, because those are the distal most muscles in the hands. So when the intrinsic muscles become weak, you will start getting clawing and finger weakness. And then the wasting of the interossei may be noted, like as a webbing the wasting, the webbing of the hand, typically seen dorsally or the posterior aspect of the hand as dorsal gut ring. So this distribution is called glove and stocking distribution of sensory symptoms and motor, also feet and hands. So actually it's the other way. Stocking comes first and glove comes next. So if you see this pattern, then it is a chronic axonal neuropathy. Right. So this we have already discussed. So this process is called dying back phenomenon, and the distribution is actually it's a length dependent distribution because lower limbs are affected first, the longest nerves getting damaged first, and the less long nerve getting affected next. Right. So we will discuss a case scenario. So this is a 43-year-old female with diabetes for 15 years and coming with bilateral numbness in feet, and it is progressive. And on examination, there is reduced sensation to pinprick, then absent ankle jerks. So now, in any neurological illness, the approach is one, what is the site of lesion? Two, what is the type of pathology? The site of lesion and the nature of the lesion. Right. So when you are confronted with the patient, you have to start broadly. The site of lesion, you must think of the whole system. You must start from the brain and then come down to the muscle. Brain, spinal cord, peripheral nerve, neuromuscular junction, muscle. Otherwise, you are going to miss. So in this case, can it be brain? Does brain produce numbness and reduced pinprick sensation? Let's say cerebral cortex. What is the type of sensory involvement if the sensory cortex is involved? In this case, it has to be bilateral. So bilateral sensory cortex involvement is extremely unusual. Oh, never happening sort of scenario. But leaving that alone, what is the type of sensory impairment you get if there's a cerebral cortical involvement? Can someone tell me?
Bilateral sensory loss.
Yeah, what sort of sensory loss do you get in a cerebral cortical involvement? Do you know? Yeah, what you get is a cortical sensory impairment. So what are the cortical sensory modalities? They are not these basic sensory modalities, not pain, temperature, touch, vibration, joint position, sense. Actually, the cortex sensors, cerebral cortex sensors, stereognosis, that is 3-point discrimination or 2-point discrimination. That sort of cortical sensory loss. So if the lesion is in the cerebral cortex, you don't get impairment to pain, temperature, touch. So pinprick sensation reduction doesn't happen with cortical lesion. So therefore, we can rule out cerebral cortical lesion on two grounds. One is the loss of type of sensory modality. The other one is distribution. Because if it is a sensory cortical lesion, unless it is a very, let's say, parasagittal lesion affecting the legs, you will not get this sort of sensory involvement. Okay, so that becomes unlikely then. Next is brainstem. In brainstem, say if it is thalamus that is involved, then the sensory impairment will be, you can get pain temperature impairment, but then it will be hemisensory impairment because the thalamus receives the sensory input from one half of the body. So it doesn't match this picture. Then we go down to the brainstem. In brainstem, the sensory impairment that you get will be again either whole body sensory impairment or one half impairment or crossed sensory impairment. When you learn brainstem lesions, you will learn this. So it doesn't get confined to the legs or feet. So now we go further down, spinal cord. In spinal cord, what is the type of sensory loss you get? Someone? In spinal cord, what you get is a sensory level below which you have sensory impairment, whole body sensory impairment below a certain level. And that level depends on the lesion, level of the lesion. Right. So again, this is, so here we will take this as pinprick impairment in the feet. So that again, it's unlikely. So now we have to go further down. We have to go down to the nerve root level. So if it is a nerve root lesion, will you get sensory impairment in the feet? So what are the segments in the feet? Dermatomal segments in the feet? What is the segment for big toe? Anyone? No one. What is the segment for heel? Well, the heel is S1. Sorry?
S1.
Yeah, S1. Yeah, the heel is S1, big toe is L5. The shin area, below knee,
L4,
L4.
medially L4, laterally
L5.
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 Yes. So L5 extends from lateral foreleg or lateral below knee to dorsum of foot and big toe, right? S1 is sole of the foot or heel, then back of calf, maybe a bit of S1 and S2, back of thigh, maybe part of S2 and S3, buttock, S3. So you sit on your S3, right? Correct. So here, if it is a L5 S1 lesion, let's say bilateral L5 S1 lesion, it can produce this sensory impairment, and it can produce absent ankle jerks. What is the segment for ankle jerk? S1. You must learn this in the clinicals, right? So, I think for anatomy they teach this. So the segment for subserving ankle jerk is S1. So if it is a bilateral L5 S1 lesion, this is possible. Then we have to consider root lesion then, but it has to be bilateral. So bilateral root lesions are a bit uncommon. So then we go to peripheral nerve, and this is possible with what type of peripheral or polyneuropathy? We have just discussed axonal polyneuropathy, right? Right. So then beyond that point, you have neuromuscular junction and muscle. Do we consider neuromuscular junction and muscle in this case? Sama?
No, because of the sensory impairment.
Exactly. Very good. So actually neurology is very simple. Very simple. You need only a little bit of background knowledge and the rest is common sense. So if there's sensory impairment, it is stupid to consider neuromuscular junction and muscle disorders. So now we are left with two possible sites of lesion, right? So by simple workout, so it is just common sense using a background knowledge. So we have two sites of lesion. So we have narrowed down the possible sites of lesion to two possible sites, polyneuropathy and L5S1 radiculopathy. And we said L5S1 radiculopathy, bilateral radiculopathy is a bit uncommon. So therefore, polyneuropathy is the number one diagnosis here. And it is predominantly sensory in this case. Motor, we don't know. When it is not mentioned, we have to take it as normal. Now the type of pathology, if it is a polyneuropathy, the pathological type is axonal degeneration. Okay, so we have made a diagnosis without even examining the patient. Okay, so this is the workout. So these are the two possible causes, and we said this is less likely. Right, so distal symmetric, predominantly sensory, axonal polyneuropathy. That's the diagnosis, most likely diagnosis. Right, so the causes, and I showed this earlier, these are the causes. I have expanded the possible underlying causes, and the metabolic, the commonest is diabetes, but there are other metabolic causes which are less common. Then you have deficiency disorders, B12 deficiency, other vitamin deficiencies, toxic causes, alcohol, lead, arsenic, organophosphate, drugs, whole heap of drugs. I have only mentioned a few. Then malignancies, not only myeloma, even other malignancies can produce paraneoplastic neuropathies, which are axonal actually commonly. Then HIV/AIDS of course can produce different types of neuropathy, like even diabetes can cause different types of neuropathies. Then genetic or hereditary, you have type 2 HMSM or Charcot-Marie-Tooth. So in our patient, we mentioned that the patient is diabetic, so possibly it is the diabetes which is the cause here. So this is another list of causes. Right, so that is axonal neuropathy, and the neuropathies can be predominantly axonal, predominantly motor, or mixed. But that is clinically. But in reality, axonal neuropathies are all mixed. Some are predominantly axonal, some are predominantly sensory, some are predominantly motor, some are both sensory and motor clinical. But in reality, all are mixed. So predominantly sensory neuropathies are diabetes, B12, alcohol, and so on. Predominant and arsenic. Predominantly motor neuropathies, lead is an example. Charcot-Marie-Tooth disease is an example, type 2. Mixed type of neuropathies you come across in organophosphate related neuropathy. What else? HIV/AIDS can produce it. Okay. And you don't see actually pure motor axonal neuropathies practically. The real pure motor axonal neuropathy is actually this entity called AMAN, which is an acute neuropathy. So chronic neuropathies are strictly, correctly speaking, they are all mixed. Some are predominantly sensory and some are predominantly motor. Now the demyelinating neuropathies. So here, the primary pathology is demyelination. So therefore, there is no pattern to the nerve involvement. It can be distal, it can be proximal, and usually they are distal and proximal. So the motor involvement can be distal and proximal, sensory involvement can be distal and proximal. I have shown here distal involvement, which is not uncommon, but you can have proximal involvement. You can have sensory impairment in the abdomen, you can have sensory impairment in the chest, back of chest, or in the face, and so on. So it's a bit difficult to identify a demyelinating neuropathy, and the pathology we have mentioned. So the demyelination process does not respect the length of the nerve. It can affect the short nerves, it can affect the long nerves. So here we will discuss another case, 42-year-old male, no significant past medical history, progressive numbness and weakness for 3 months, and he has difficulty in getting up from chairs and unsteady on feet. Then examination revealed moderate symmetric proximal and distal weakness, upper limbs and lower limbs. Then sensory examination reveals light touch and pinprick sensations are reduced in stocking glove distribution. Now, don't get carried away by this, and the reflexes are of course absent, because your weakness is proximal and distal. So, when there is proximal and distal weakness in the upper limbs and lower limbs, so a differential diagnosis, once again, we will consider from the brain. It's a bit unusual to produce a cerebral cortical lesion to produce proximal and distal symmetrical weakness. For that, you have to have bilateral extensive motor cortex involved, which is very unusual. Then when you come down to the brain stem, if you have upper limb and lower limb weakness, you can get this in brain stem lesions, but then usually you will have either loss of consciousness, or you will have, because of the reticular activating system involvement, or you will have cranial nerve signs. So when it is not given, you have to take it as there are no cranial nerve involvements. So then you come down to the spinal cord. So if it is a spinal cord lesion, then we mentioned that the sensory involvement will be a sensory level. So if the upper limbs are involved, then the lesion has to be at or above the cervical level. So then there must be a sensory level at a cervical level. But the sensory distribution is distal, glove and stocking type. Therefore, spinal cord lesion becomes unlikely. So now we go on to the nerve roots. So can this be a root lesion? If it is a root lesion, then it has to be a multiple root lesion because upper limbs and lower limbs are affected widespread. Next comes the peripheral nerve lesion. So now again we are left with root and nerve. And it's difficult to differentiate the two here. You can have multiple root involvement. Generally, common root lesions are only affecting one or two segments, but rarely you can have, or not that rarely, but you can have multiple roots getting affected. And that will be actually a part of neuropathy usually. So we call them radiculoneuropathies or neuroradiculopathy. So here it's difficult to separate the two. So it falls into this category, radiculoneuropathy. It's not axonal because it's not length dependent. So therefore, it must be demyelinated. So this is the typical presentation of a demyelinated neuropathy. In this case, it is short duration, but it can be sometimes long duration. And the causes are here. Out of these, the relatively common cause is CIDP, chronic inflammatory demyelinating polyneuropathy. Then less common causes are paraproteinemia and drugs. And the cause drugs you can identify from the drug history. Paraproteinemia you have test and find out, but this is uncommon. So if you don't really find, do not find an underlying cause, most likely it is CIDP. Now I have not put hereditary neuropathy here in red because the clinical presentation of hereditary neuropathy, Charcot-Marie-Tooth disease, is different. It is different from other demyelinating neuropathies. So you can actually separate acquired demyelinating neuropathies from hereditary demyelinating neuropathies on clinical grounds. In actual fact, hereditary demyelinating neuropathies resemble axonal neuropathies. They will have distal motor weakness and some sensory impairment, which are very subtle. Actually, patients may not even complain. Will you believe that there is a sports person who has hereditary demyelinating neuropathy and gone on to win medals, and he was the best so far in that country. He has been the best performer so far in that country, who has won the largest number of medals, and he went unnoticed. He didn't have any symptoms and he performed so well. And then he retired from his sport and became a coach. And after he became a coach, he had some mild sensory symptoms and then came for testing. Because he was just worried why this is happening, and to see he has this entity. So he actually has signs. He has distal mild deformities, which we have mentioned earlier. He has some deformities. And it looks like an axonal neuropathy, but he doesn't have much weakness, doesn't have much of a sensory impairment, has mild symptoms. So he went through his career and he retired and he became a coach. And even after several years of coaching, he got mild symptoms. And the symptom signs, they look like axonal neuropathies. So this is the difference between acquired demyelinating neuropathy and hereditary demyelinating neuropathies. In hereditary demyelinating neuropathies, the demyelination is widespread. In acquired demyelinating neuropathies, the demyelination is happening only in segments. So therefore, we call them focal segmental demyelinating neuropathies. And that is the reason for widespread and sort of patchy distribution of symptoms signs. Okay. Now we will go on to investigations, and investigations you don't have to buy heart. You can work out. When you remember the list of causes, you can decide on the investigations. And this is largely supported by identification of the pathology. If it is axonal neuropathy, the types of causes are one set, and if it is demyelinating, it's another set. So, nerve conduction study or electrodiagnosis is one of the most useful investigations. It helps confirm the presence of polyneuropathy and also identifies the pathology, whether it is axonal or demyelinating. And you might even pick up silent lesions, which are asymptomatic nerve involvements. And you can also identify the distribution. Then when you identify the type of pathology, it gives a clue to the etiology. I have given a list of causes and I am putting it again. So based on the causes, you can decide on the investigations. So you start with this one. Then if you suspect it's axonal neuropathy, then you can look for blood sugar to diagnose diabetes, see whether there's diabetes. Then you can look for uremia. You can look for blood counts will help to identify B12 deficiency or myeloma or some other immunological derangements. You can directly do B12 levels. ESI, of course, is non-specific. You can suspect malignancy if the ESI is high, myeloma, for example. In serum protein electrophoresis for myeloma or other paraproteinemias, monoclonal gammopathies. Chest radiography is useful for identification of lung cancer, for example, or you can go on, if you want, you can do CT chest. Then nerve biopsy. Nerve biopsy will confirm the presence of neuropathy, but this is not essential for diagnosis of polyneuropathy. And it will also identify some of the causes, like vasculitic neuropathy. We will come to this in our next lecture, vasculitic neuropathy. It helps to identify leprosy, amyloid, and for example, but the utility of nerve biopsy is actually limited. It's not as promising as you would think. But in correct situations, it's useful. Now the management. And the management is based on these principles, and actually these principles can be applied to management of any illness, not only neuropathy, not only neurological diseases, even non-neurological diseases. First is to reverse the etiology. So if you suspect, say, the patient is having a neuropathy due to a toxin or a drug, you can stop it. Then you can think of specific treatment for the cause. Some of the conditions have specific treatment. For example, if it is hypothyroid neuropathy, you treat hypothyroidism. If it is diabetes, you treat diabetes. Then you can prevent further decline of function, and this is partly by giving specific treatment and partly by supportive measures. Then symptomatic management, because the patients may have symptoms like pain, discomfort, dysesthesia, and so on. So those can be treated symptomatically. Then finally, prevention. Right. So that's a little break. Now we will get on to examples. Now, peripheral neuropathies in diabetes. There are actually several types of neuropathies in diabetes. One is distal symmetric polyneuropathy, which is the commonest. Then you have what we call diabetic amyotrophy. The newer term is diabetic lumbar radicular plexus neuropathy. Then you can have small fiber neuropathy. You can have autonomic neuropathy, and then you can mononeuropathies. But we will deal with distal symmetric polyneuropathy. Then there are some treatment-related uncommon neuropathies in diabetes, but we will deal with this one, which is it is also called classical diabetic neuropathy in colloquial communication, but this is the correct term. And this behaves like a typical axonal neuropathy. It is insidious in onset and slowly progressive and start in the feet, and sensory is more prominent. It's symmetric and they can have nocturnal cramps as we mentioned earlier. And then can have some motor involvement as well. And is associated with poor control of diabetes and also associated with microvascular complications. So therefore, if ever you come across a patient with diabetic neuropathy, don't forget to look at the optic fundus. Look for diabetic retinopathy and also screening for blood flow in the legs and also the renal function. So diagnosis can be done clinically. We have already diagnosed some an axonal neuropathy previously, and you can use nerve conduction for confirmation. And you can screen for diabetic neuropathy by threshold testing. You can use a monofilament test for this purpose. If you visit the diabetic clinic, you might come across this. Then the treatment. The best treatment is good glycemic control. There is no proper specific treatment. People have tried GLA, gamma-linolenic acid, and alpha-lipoic acid. It's supposed to be useful, but they are not really strictly proven. So there is no specific treatment here. The specific treatment is good glycemic control, and the rest is supportive. And the best approach will be prevention. Right. So the next one is chronic inflammatory demyelinating polyradicular neuropathy, which is a demyelinating neuropathy, as we mentioned. So this is why I said radiculoneuropathy, they go together in demyelinating neuropathies. It can run a slowly progressive course, chronic progressive demyelinating polyneuropathy, as it was called in the past, or it can run a relapsing and remitting course. Relapse, remit, relapse, remit. And it is insidious in onset, but it's sort of subacute sort of onset is there, and by definition, it has to progress over 8 weeks. The symptoms have to progress; they have to gradually develop over 8 weeks. That is by definition. But rarely you can have shorter duration progression, and then it can mimic Guillain-Barré syndrome. Unlike in Guillain-Barré syndrome, there is no antecedent infection here. So clinically, they will have predominant motor symptoms. They can have proximal and distal weakness, and the sensory symptoms can be variable. They are very often they are not very prominent. They can be distal, proximal, anywhere. And cranial nerve involvement is very uncommon, and the reflexes will be absent. Then you can actually clinically suspect and confirm the diagnosis by the nerve conduction study. And the nerve conduction study will only mention that it is a demyelinating neuropathy. And it can also tell you that it's an acquired demyelinating neuropathy. So the moment it is an acquired demyelinating neuropathy, you must exclude underlying cause like paraproteinemia, for example, and exclude drugs. And then you can rarely have acquired demyelinating neuropathy like picture in some other hereditary conditions like leukodystrophies. Then you can do a CS examination. Here, CSF shows elevated proteins in normal cells. So it shows a albuminocytologic dissociation, which you also see in Guillain-Barré syndrome. So this is the category that this falls into. You must exclude other causes, as I mentioned, like especially paraproteinemia. And I have come across patients who have not been suspected of paraproteinemia after nerve conduction. I have suggested, and they actually have had paraproteinemia. Once we confirm that it's a demyelinating neuropathy, to confirm CIDP, you must exclude these underlying causes. So treatment of CIDP is with steroids. You give prednisolone. And in the acute phase, if there is a very severe weakness, to overcome the acute phase, you can give plasma exchange or immunoglobulins. And in long-term steroids, if they don't respond to prednisolone, you can give cytotoxics like cyclophosphamide. Or if they get severe side effects for steroids, you can use this, which is called steroid sparing therapy, steroid sparing strategy, because the steroids are producing severe side effects. Then of course we have to use supportive care. Right, I think that's it. Quickly about acute polyneuropathies, when I have already mentioned this, you can have acute pure motor neuropathy, which is Guillain-Barré, A-man. Then acute mixed neuropathy can be A-man or AITP. But you must exclude other differential diagnoses. Non-neuropathic conditions can look like acute neuropathy. Then acute sensory neuropathies can be sensory Guillain-Barré. Acute ganglionopathy. Ganglionopathy is not really a neuropathy, it's the dorsal root ganglion involvement. And you can also have acute small fiber neuropathy, extremely rare condition. But I mentioned this because this was described in this country for the first time. I think you are having another lecture on, you will have a lecture on Guillain-Barré syndrome, a separate lecture. So there they will deal with acute polyneuropathies. And this is the category that it falls into. Okay, so I think that's it. And as required by the faculty, I am showing the objectives again. And a reminder to give you feedback. I think this one will be on your Google form. Have you posted any questions? Or any questions? You can ask verbally if there are any questions. No questions? Do you hear me?
Yes, sir.
Yes, sir.
All
we
right,
can.
good. Okay. Everyone is very silent. Any questions? No questions? Okay, if there are no questions, we will stop now. We are right on time. So next time we will do this. Next time is tomorrow, same time. Okay, so then I'll stop now.
Thank you, sir.
Right, thank you.
Thank you.